Yeah.
All right. So, welcome everybody. I'm Leslie Hammond. I'm the Membership and Marketing Director at the Home Care Alliance of Massachusetts. And this is part of our monthly series for business development. Today we have Jonas Fortenberry from Palm Safe. Um, and we do offer business development programming once a month for free for our members, for our would-be members. Um, and hopefully to help you get connected with what's out there for services, but also we had marketing support last month, and we've gone over wage and hour law with kind of the gamut. But today we're going to focus on a really important topic, and that's our workforce safety. So Jonas, if you would like to share your screen, we can, oh, or are you already sharing your screen? My box went away. Oh, there it is. Okay. So I have two screens. So yeah, so take it away, Jonas.
Wonderful. Hopefully everyone else can see. And I see a few people popping into the waiting room, so we'll let them in as we go. Hi, everybody. I'm Jonas Fortenberry. I'll tell you a little bit more about myself and my background once we get started. But as Leslie mentioned, I'm the VP of Development at Palm Safe. We're a safety solution software built specifically for post-acute and home-based care. This is not a commercial webinar. This is really an educational webinar about safety committees and the role of safety committees and the growing role of safety committees. Um, Specific to home-based care. It's something that's close to my heart. And again, I'll talk a little bit about that and kind of why I came to where I am, and very just excited to kind of share with you some learnings, some places to start if you haven't started a committee, some things maybe to use to optimize if you do have a committee already. Really, we think about this as something that can help support whether you're just beginning your journey on kind of safety and workplace violence, or you've got something that is more robust and further, fleshed out. But everywhere from beginning to in between to, very sophisticated, hopefully there's some tips and things you can find through here. So we'll cover some objectives and agenda. Then we'll jump into the presentation. Some things I may go a little faster than others just to try and get us through the hour. But this is also a little bit of a choose your own adventure. So if you have some questions, please pop them in the chat or just raise your hand and speak up and say, "Hey, Jonas," and we'll stop and gather that. We also have some time in the end to answer any questions. We'll have resources, pages, a lot of links we can send out for some tools and toolkits to provide as well, assuming you'll get this presentation afterwards. So we're going to understand the need for and the role a workplace violence safety committee plays in your organization. What are the types and how do you develop an effective committee structure? And then some stories and how to implement some proactive safety strategies around that committee and the role the committee plays and things that you can do within that committee structure to be more proactive in promoting a culture of safety. And we'll talk about some examples from people that we talk to. Part of my job is traveling around the country and speaking with other agencies and understanding what they're doing, where they are on that journey, and hearing stories of things they've done to promote, like I said, that culture of safety in their organization and learnings from that. So starting there, a culture of safety, you'll hear me say that a ton during this presentation. And that really is one of the most important things in all of this. And we'll show some stats around that here in a little bit. But really, what a safety committee does is really help promote that culture of safety. And when I say the culture of safety, it's something that, again, is near and dear to my heart. I'm a former administrator in home health and hospice. I had an agency that I joined as a partner in Akron, Ohio, so Northeast Ohio near Cleveland. And in 2015, I took over all of our non-clinical functions of the agency. So managed our marketing, our intake department, authorizations, fights over the thermostat. Leslie mentioned how cold it is in their offices there, to shoveling snow. But there's a story that that sticks out from 2015, and this picture there on the screen is what's called the Mayflower Building, and many of you may have some kind of version of this in your areas, but it's a senior high-rise community in downtown Akron, and we were out at a happy hour, one day during the week with some nurses, some other caregivers, some of the office staff. And one of my nurses pointed over the building, which is just catty corner to the restaurant we were at, where we were having drinks and appetizers, and said, I hate going into that building. And I asked why, and she said, it creeps me out. The people in there, say things to me or say, hey, pretty lady, or, you coming to see me, or, something like to that effect. And my first response, more so out of ignorance than anything else, because at that time it's patient safety, patient safety, was, well, that's too bad. Not tell me more about it. Tell me more about how that made you feel. We didn't have a reporting structure in place for people to talk about, what we call, and we'll talk about here, near misses, or risks, that you want to share, where we could have done something about it. My first inclination was, well, it's too bad. That's part of the job, and hopefully the patient gets taken care of. And I talk about that miss and I think about that miss a lot, in where the role I have now and the people and the agencies I visit across the country, because you hear so many similar stories. And really the learning within that is it's not just part of the job. And because an incident didn't specifically happen, we call violence, doesn't mean that workplace violence, wasn't present there. So we'll start there in terms of defining what workplace violence is. And forgive me for some of you, again, that have, maybe further along in that journey, and this may be a little bit redundant to you, but I think it's worth talking about because more often than not, we think of workplace violence as something physical. And it really isn't. The most times it happens is a threat, a harassment, a physical or verbal abuse happening, then bullying, and then assaults is what most people think of, some kind of physical confrontation. So it's all encompassing. And when you talk about violence, you have to really think in that space. And are we giving our caregivers and our clinicians and field workers out there, the safe space to communicate that feeling of, a threat or harassment or some kind of abuse? So when we talk a little bit further defining violence, there's four different types of workplace violence from OSHA and NEOSH, the National Institute of Occupational Safety and Health. There's criminal intent, and we'll go through each one of these, and that's type one violence. So this is where there's no relationship to the business or the employees. Usually this is something like a robbery, a trespassing, or in healthcare would be a nurse maybe assaulted in a parking garage or parking lot, or accosted while they're conducting a home visit or walking into a home visit via the neighborhood, or in that example, the Mayflower building, down a hallway. Type two, this is when we talk about client on worker violence. This is obviously the most common in healthcare settings. And so this is, considering the customer or client or patient relationship to the caregiver. So it could be the patient, could be family members or visitors. Again, most common. The third is worker on worker. So again, this is something still to be aware of when you talk about workplace violence in a safety committee is, that third one around bullying or verbal abuse. This is between coworkers. And so really this frequently manifests itself as verbal or emotional abuse that's either unfair or vindictive or can be, humiliating. So it's part of something you want to include when you talk about having a workplace violence prevention policy. And the fourth one is personal relationship. So this is where the perpetrator may have a relationship to the caregiver outside of work that comes and spills over to the work environment. We actually had this come up recently with an agency partner of ours where the agency could not get a hold of the nurse, and they were trying to figure out where she was, had not made her next visit or checked in for her next visit, and couldn't get a hold of her, and so used a palm to find out and find out where she was and finally connect. And ended up it was a personal relationship where the husband had followed her to work, and kind of like I said, derailed her day. And so knowing that and being able to communicate that and include that as part of their policies, and understanding that is something that constitutes workplace violence, helped kind of define better what they were doing in terms of policies and procedures as it relates to personal relationships in the workplace. So further defining workplace violence a little bit, this is, I don't know how many Joint Commission accredited agencies in there are in here, but the Joint Commission did actually put a definition of workplace violence in their accreditation manual for home care. And you can read this here, but basically, like we talked about earlier, it's anything that includes verbal, nonverbal, written, or physical aggression. And that can be threatening, intimidating, or harassing, or using words. And then up to including physical assaults. And it includes staff, practitioners, patients, and visitors. So all encompassing all of that. Further beyond defining workplace violence in that accreditation manual, they issued a couple updates beginning in January 2025. Two new and one revised. And what they said in that alert was that workplace violence continues to pose a significant occupational hazard for home care workers. One of the biggest issues is underestimating that due to underreporting. So someone perceives it as minor, or they're not really given a way to report some kind of incident or potential incident. And so they also said, moreover, that the lack of action or the normalization of such incidents exacerbates the issue. And so they also, as part of that, wanted to make sure that people knew that not receiving training or not receiving policies was part of that problem too. They said they found that 62.5% of home care workers indicated receiving training related to workplace violence. So over 40% did not. And so that's a high number and higher than it should be. So the revised update was that they developed a process for monitoring, reporting, and investigating safety and security incidents, including those related to workplace violence, as you can see there. They added a new one, and these are the elements of performance of that an organization needs to have a workplace violence prevention program led by an individual. And we'll talk about this, who is part of that committee. But they do at least an annual analysis of safety and security risks, that they have policies and procedures in place, an easy process to report incidents, and a way to track that data so that they can analyze incidents and trends. So we can talk about we'll talk a little bit about what that looks like a little bit later. Then the second new element of performance they added was, as part of that, they need to provide education, training, and resources. And so, the purpose of a workplace violence prevention program is to make the leaders and the staff aware about the potential of violence in the workplace, increase that awareness, understand and track early warning signs of situations that may turn violent, and then how to respond to those actual or potential incidents, and understand, that all acts of workplace violence need to be, addressed promptly, investigated, and understood. So I think that's is really important because, again, the Joint Commission is taking this on. I actually met at the New England conference earlier this spring with CHAP, and they mentioned that this is likely going to become part of their standards starting next year. So they're looking at that as well. So again, the Joint Commission update, just kind of packaging all together, that there needs to be, training, education, resources, and a formal, workplace violence program in place, um, and that others are kind of taking part in this as well. Further on that, and then we'll just touch here really quickly, is that there's a number of states with active or pending legislation, and these are specific to home-based care. There's a lot, I believe, gosh, closer to two-thirds of states have something in place that relates directly to facilities or to hospitals or emergency departments. But one of the biggest things lacking is language and specificity around home-based and community care workers, so people that are outside of facilities. And so these are states listed here, and Massachusetts is one that has either active or, in this case for Massachusetts, pending legislation related to home health care workers. And the bill in the House and Senate for Massachusetts was in committee, and I think there was an update where they were having a committee meeting on this as recently as middle of June. Um, Key themes in all of these, including the one that's right now in Massachusetts, is that agencies are required to conduct safety assessments, so risk assessments, understanding before, taking on a patient, before sending a caregiver into the home, having a violence prevention plan and policy in place, and then having training to protect employees from workplace violence. And then, of course, I'm sure everybody knows that OSHA has the general duty clause that requires that you provide a workplace free of known hazards, and that includes the home. That's not just a building. And actually, a lot of times when I say this and talk about this, I mentioned back in my days as an administrator, one of the things, and I ask people to raise their hand, is how many of you in your offices have a locked door to get back into either the main office or even just into the front door? And more often than not, most people raise their hands. But when a caregiver goes into the home, they don't have that ability. They are walking into someone else's home, and that becomes the office setting. And so always remembering that as part of, arming and providing resources for caregivers that, they don't have because they're not in a normal office situation. And last but not least in here, federal legislation, there was from OSHA, there was going to be expanded guidance or proposed rule, I guess you'd say, at the end of last year. It didn't happen. But on April 1st of this year, Congress did reintroduce the Workplace Violence Prevention for Healthcare and Social Services Act. And it does a lot of the same things. And I'll go through these just very quickly that the state ones do, where there would be a federal safety standard that would cover home health, and it would require them to have those certain things. The Workplace Violence Prevention Plan that's written, have risk assessments and a way to track those, easy incident response procedures and protocols, and then how to keep records of those and report them as well. I'll pause there briefly in case anybody, I don't think I've seen any raised hands or anything in the chat, but if you have any questions or there's anything to add, please do that. Okay, before we get into kind of you know the kind of the case, I guess you would say, of a committee, and do we really need another committee? Want to talk a little bit about the extent of the problem, and a lot of times people say, well, we don't have a problem, we haven't had an incident, we don't hear people say anything about this, and I equate it to just like PPE. If some people wear gloves for certain reasons, they have take certain precautions with needles and other things. This is just another function of that, but it's related to me personally as a person in the home. So I want to do this. This isn't really ability to be interactive because we're not in person, but I'd love everybody just kind of think in their head when they see these numbers. What do you think this number relates to? 96.1%. Give you a second to think about that. Most people get this because when we talk about relating to the problem, but 96.1% of healthcare professionals have experienced verbal abuse or intimidation in the workplace. So almost everybody, at least that verbal abuse or intimidation, and that counts as workplace violence. Next up, 47%. I think this is one of the most telling and the most important as we talk about the reason to establish a committee, and the reason to give caregivers a voice. 47%, only 47% of nurses report incidents to their employers. And the main reason is due to perceived lack of inaction from management. So if a staff member doesn't see action, they stop speaking up. And that silence puts everyone at risk. I carry the guilt that that was my blame. It was, for me, I was to blame at my agency for this, and that I heard something and didn't take action. I took it as part of the job or make sure the patient is safe. Behind that 53% number of, don't report. Those are unreported events, and those are warning signs or red flags that never make it to leadership. And so safety committees help build that trust by creating those processes and helping close the loop with field staff and give them a voice to do that. All right, last one, and then we'll jump into the case for committee. We'll talk about the functions of a committee. 20%. This one is kind of a little bit of a different kind of number because this talks about productivity. 20% of workers, or sorry, not 20%, workers exposed to violence experience a 20% drop in productivity. So even if an incident doesn't result in physical harm, there's emotional tolls. There's fear, anxiety, distraction, things that reduce focus, efficiency. And this is, especially important in home-based care because staff are already working independently. So when we talk about a drop in productivity, that could be delayed visit, incomplete documentation, which is super important, missed clinical cues, so miss something in terms of taking care of the patient. All of these directly affect patient outcomes. So when workers feel unsafe, they spend less time engaging meaningfully with patients and more time thinking about how to protect themselves. And it's really a bad thing in that the number one thing and the most, telling thing is people want to be in this business because they want to take care of people. But when you're also on top of that, having to be your own security guard, your own potentially cleaning person in the house, traffic cop, all these things, you can't deliver that compassionate, attentive care because you're scanning for exits or you're texting a colleague about being worried. Your staff carry that trauma and it spreads so that one violent or one threatening incident doesn't impact the caregiver just by themselves. It affects the whole team because staff talk to each other, morale drops, turnover increases, and then patients also sense that instability. So the safety committee, again, important to break that cycle because you address threats early, you offer support to those caregivers to be able to speak up, and you show staff that they're not alone. All that gives us to the place of why a committee. A safety committee is, specifically in existence to challenge those norms, create new expectations, and make it clear that safety is a right and it's not a trade-off. The perception that it's just part of the job is not true. If you make it too difficult to report something, or you don't have policies in place or procedures that staff know what to do if something happens or they have some fear of something happening, you're driving that instability and you're driving that inefficiency in terms of what we talk in terms of productivity. There's a thought that it will reflect poorly on the caregiver, or that it doesn't matter because nothing's going to be done. A patient will be held accountable, and we'll talk about that because there's specific things you can put in place, kind of with that patient kind of bill of rights, if you will, and the things that are part of an intake packet that you have a patient or family sign off on that they're going to agree to do to be held accountable. And most important on this one, that complex reporting procedures we'll talk about. You can streamline reporting, you can simplify access, you make sure that the frontline staff know exactly what to do, and the committee kind of helps with that. Um, So why does that matter? You're reducing risk and liability. Committees help identify patterns, close gaps, and help, like I said, proactively prevent harm before something happens. They demonstrate that you're doing your due diligence, which again, increasingly important because of OSHA guidance, the new Joint Commission standards, pending and upcoming state regulations and staying ahead of that. More importantly, promotes a culture of safety. I was going to say that a few times, and here's one of those. Safety, when it becomes part of the routine conversation, it stops being reactive and you're stopping doing something being reactive about it, and it becomes a proactive situation. The safety committees give the staff a platform to be heard, to identify concerns and then to co-create solutions. And we'll talk about that in terms of who is on your safety committee, because it helps do, that in terms of creating solutions based on what you're hearing in the field and having leadership be involved. And that all ultimately builds trust, shows your organization is serious about protecting people and not just checking a box. And then talk about dollars and cents. It supports recruitment and retention. We know that people want to feel safe doing their job. We know, and I know traveling across the country, that agencies that highlight their safety efforts, including having a dedicated committee, stand apart in a competitive hiring market. And it becomes a differentiator and it builds loyalty, it reduces burnout, increases likelihood that staff can stay. How many of you have, the idea that a nurse could go or a caregiver could go leave your agency and have a job by the end of the day somewhere else? That's true, and it's going to become increasingly more important because of the competitiveness and the growth of this industry and the people that are getting older every day. Okay, nothing in the chat yet. So we're going to talk about the key functions of a safety committee. So what are the reasons? We talked about the reasons and the reducing risk. What are those functions that they do? We talked about risk assessment. Before you can fix something, you have to be able to see it. So the committee's job is to proactively identify and evaluate those safety risks and not just after something happens. So you're reviewing incident data in the EHR or the reported view of phone calls or software like a Palm, near misses. So those things where someone just kind of says, hey, I didn't feel comfortable because of this, and tracking those and understanding, is there a pattern in an area, a time of day, a specific patient, allows you to identify high risk zones, and then those patterns. So, scheduling or staffing, who goes or when they go, and what contributes to unsafe conditions in that sense. Policy development. We talk about policies being your guardrails. And those should be built and kind of influenced by people who use the road, so your caregivers out in the field. So the safety committee helps write and revise those policies based on, again, those things with the risk assessment or things that you understand when you identify patterns. So you're revising policies that, become practical, make sure they're enforceable, and they keep the staff informed. Those include things like escalation protocols, I mentioned it earlier, a home visit refusal policy, or the expectations. So when a patient comes on, they're signing something in the intake packet that says, here are the expectations in terms of things like drug use or guns in the home or people and family or guests in the home during visits. Third is incident response. So what happens after someone reports something? And when I say an incident can be that near miss. So something in terms of I felt unsafe or something happened here. And so what happens when someone does report something? That says everything about your culture. And the committee helps ensure that there's clear, timely, and supportive processes for responding to a threat, an actual assault, or a near miss. So those could include things like debrief protocols or safety reassessments, or staff support services. We were with an agency last month, um, talking about reassessments. Something wasn't reported in the intake procedure, and they make a call. They ask the family, they ask the patient before they go see them, and something wasn't reported. And it didn't come up until maybe the second or third visit. It was reported because they had that channel of communication back to the office staff that there was something there that was missed or wasn't communicated during that intake process. And so for that next visit, a supervisor went out and reintroduced the policy, and made them sign to say, hey, we're agreeing to this part of the policy as a patient, or else I'm not going to be seen. And then the last is education and communication. So safety training isn't a one and done thing. It's not something you do just at onboarding. It's ongoing, it's visible, and it's relevant. And the committee and someone specifically in a role in the committee leads those education efforts by bringing people in and help keep safety top of mind, with updates, refreshers, and staff input on what you're seeing or what they're hearing, so they can build education around that. Okay, so we talked about functions of safety committee. What about building our committee? It needs to be a multidisciplinary approach. And then the other thing that's really important is that leadership buy-in is crucial, because a committee is not just a group of people in a room. It's a team that has a mission, And every team needs to have leadership buy-in and define roles to succeed. So make sure you have responsibilities because if you don't, things fall through the cracks. Follow-up doesn't happen. Your decisions don't get made, and staff lose that faith. So you need to include staff from clinical, HR, the field, and operations. You need to make sure you define those roles clearly, and then you need to have a regular meeting cadence. So those are key things in terms of building the committee. So when we talk about that, what are those roles? If we have people from clinical, people in HR, people from the field, anyone in the office, what are some of the roles that are there so that we know what they're taking, care of? Make sure you have a chair or facilitator. And when I say start a committee, you can start it with a committee you already have. We've talked to organizations that use their IDG or IDT committee. That is their first safety committee, or they use their QAPI program and build that in, for their committee. Or they engage and include it as part of their emergency preparedness planning in that group that defines that. So there's you don't necessarily have to go reinvent the wheel. You might have people in your agency already that are doing this that you can just tack on and have a separate committee as part of that. So chair facilitator, they guide the meetings, help, follow accountability. A data lead, so someone that is collating all those things for your monthly or quarterly meetings to understand trends or your review reports. If something, someone communicated something through a system or through a software or through the EHR. Your field staff reps, so they bring in that frontline insight. So what are you hearing? What are you seeing? I met with a group in, oh gosh, somewhere in the Midwest, Kansas, I believe, that has monthly meetings where they ask field staff to give, think of a suggestion box, but they give it out loud. And they reward them for that. They cheer that they're giving, things that they're seeing or hearing in the field, and they celebrate that, which I think is really cool. And then a training liaison, so someone helps drive the education and then the rollout of any changes you may make in a policy or procedure and how that gets communicated to the staff if you're changing some kind of protocol. Okay, so we talked about kind of the key themes in the committee, who's on that committee, what are the components of the committee? When we talk about policy development, the risk assessments, what does that look like? What are some things that you need to kind of think about or make sure you include in that? The committee we talked about earlier, it's not just a box to check. This is an engine. This is driving how your organization understands risk, responds to incidents, and kind of protects those people. It's the central nervous system, I guess, if you will, of your safety culture. It senses what happens, it's what's happening, it coordinates the response, and it helps the organization kind of learn, adapt, and continue to develop. So these next few slides are going to walk through those core functions that you should own, from the policies to reviewing incidents and guiding training. Policy development, and I'll provide this with the deck out of here. There's a lot of templates that you can use if you don't have anything for policy, but you should have a zero tolerance policy. There should be a detailed response protocol. So the moment a safety incident happens, that's not the time to figure out what to do. Your plan should already exist. So, clear step-by-step process on how to report, and you need to make it easy, whether that's with the software, whether your existing software, some kind of, program to be able to make that easy for someone to do. And there's a lot of different ways to do that. Guidance on when you're supposed to notify just leadership, you should call law enforcement or do other things if there's some kind of ongoing threat. And then patient handbook, we talked about that. Safety is part of the care contract, and the patient needs to understand that from day one. So your language and the patient rights and responsibilities should be in there about respectful behavior and what happens if staff are threatened. That also is very important in protecting your agency from liability, and it supports the staff if there's difficult decisions that need to be made in terms of care. This is time if I'm in person, I like to ask people to raise their hand if you or that people on your team would know exactly what to do step by step if they were threatened during a visit. And so I just say to think about that of if you know or if you think that your staff knows if they know step by step. And then second, do you have a zero tolerance policy, a written policy against workplace violence? Okay, from policy development, we're going to talk about conducting risk assessments and what that looks like. Um, you can start with the data you already have. So if you do have some kind of incident reporting tool, whether it's HR logs or just some kind of more ad hoc field staff feedback or notes in the EHR that your clinical supervisor are reviewing, you can use that just to start before you get something more structured in place, because those incident reports or those things in the notes are your data. That's where you use to spot trends like time of day, geography, specific patient profiles. We talk about a lot in some of our trainings around, how to assess and how to address different diagnoses types. A bipolar person different than a dementia or Alzheimer's patient, different than, someone that's over with a knee or hip or something like that. And then the types of threats. So understanding what the type of threat is and what, action, what to do out of that. You can use OSHA and other tools. If you don't have something, you don't have to build your policy from scratch. And again, we'll provide some links. But OSHA has a workplace violence prevention checklist. The association I know puts out tools. NAC has some links that we can put to. And then if you're Joint Commission accredited, there's guidance there as well. So pull all those together. Those tools are going to help you kind of standardize how you're going to say you're going to identify a risk or score it and see any other best practices. Another way to understand and conduct kind of that risk assessment, both at intake and just general, is mapping your high risk areas. And we talk to a lot of folks who say every area is a high risk area, and that's true, but not all areas carry the same risk. And your strategy should reflect that. Are certain zip codes seeing more threats, whether it's from crime database or from reports in the field? Are evening visits or hospice admissions showing higher risk? I met with a group in Virginia, a hospice group specifically, and they said, well, we're hospice. We don't have high risk patients or areas because we're doing end of life care or hospice. And I just asked the question, how many times does someone go to a home and the family there agrees that mom or dad or brother or sister, aunt or uncle should be on hospice? And that caused them to kind of stew over that for a couple of minutes and understand, okay, yeah, there's a lot of tension in the house because of that. And then I asked, how many times is someone on hospice super convenient and they pass away at noon during the daylight hours, not in the middle of the night, not when you're, walking to the house with a medical bag or things like that. It's just the perfect daytime routine. And they said, okay, didn't think about it that way. And so that just started a conversation around um, understanding or asking the question of what do you deem high risk and what that looks like. And so they determined that there are some issues there are some gaps in that hospice world. Are certain roles, we talk about roles, are they disproportionately affected? Are aides being more verbally abused, versus an LPN or versus, the nursing or an on-call nurse who may not be someone that goes there all the time, so they're more foreign to that person? Is that some kind of, disproportionately affected role that maybe there's something more you need to put in place? So these are things to think about when you talk about a risk assessment. It's not just one thing. It's all these things in terms of data, understand what is the risk there. Once you map that or once you kind of pull that in, you can use that to tailor your safety protocols, like adjusting scheduling, or implementing technology solutions, in these hotspots. We talk about, check-in timers, or other tools that you can use if it becomes what we deem kind of a high risk visit, or a lot of times people put policies in place for a first time visit. It's a start of care. We've never been in the home. So that's high risk just because we've never been there. And so certain protocols get added because of that. And that's what, again, the committee helps talk through and understand and put that as part of the protocols in place. Um, Last one, this is a little bit less in terms of, or some of these a little less because we're talking about field, but still we're talking about this is building controls, and then prevention strategies. But these are still important because every house, every community, every apartment, everything you go in, is a potential for documentation in terms of communication with other staff. You don't have just one nurse or one aide going into a home. There's a team of people that are going in. Um, so, the best safety plan is one your team can access in real time wherever they are. So mobile connected safety tools, GPS enabled apps or devices, something that gives staff an immediate lifeline when they're working alone. These help agencies respond faster, more easily document alerts or risks, or we call those near misses, and track usage patterns to understand and improve the support. Put in check-in, check-out protocols, not EVV, not did you check in on time? Or were you there at this time and place? But more so, if someone doesn't check out or someone doesn't leave a visit, would you know? And so we talk about that first visit for the start of care, the first time you've ever been there. If you have a structured check-in or check-out procedure, that creates accountability, but also peace of mind for staff and the supervisors. So for high-risk patients, late day visits, things like that, just saying, hey, I'm checking in and I'm checking out. And if I don't check out, someone's going to check on me. They're going to call me, whether it's the office, whether it's a dispatch company as part of a solution, or something else. That's just again adding that peace of mind for understanding that someone has some help and support. Then we talk about lighting, exits, threat signage, things like that. So the threat signage documentation is more for a building. But communicating things, and we talk about this at Palm, with our mobile app a lot. There's a function that we kind of call Waze for nurses. So think when you're driving in traffic and you use Waze and you point something, there's a cop on the side of the road, or there's an accident here, or there's something on the side of the road. That's protecting and letting people that are coming later understand that there's something to take note of there. And so if a nurse or caregiver doing that start of care notes something, just as simple as accessibility of exits or hallways not being well lit, or people standing milling around outside the Mayflower building in my instance, that they can note that quickly and easily. And if I'm the therapist coming in 2 or 3 days later, I'm able to see that, whether that's in the chart or whether that's in a safety tool that alerts me based on the location that I'm coming into something. It's that shared kind of responsibility of communicating a known threat, and reducing that liability for yourself and for the people that follow. Okay, training and education. Training is a core part of prevention. And so certain things like what to do in terms of body posture and tone, how to identify accidents, where and when to place yourself and when to leave a home visit, and letting people know what that threshold is to say, I'm going to step out. Um, Again, I like to do a raise hand here. Just think about this. Have you received or have you, been a part of formal de-escalation training in the last year with your organization? And the second question I want to ask and think about this is, oh, there's one. Raise your hand or kind of think about, have you ever had to, and I think most people are going to raise their hand here, especially if they've been in the field, had to trust your gut and leave a visit early? Most people here raise their hands, whether it's coming up to a visit and thing, I've got that uneasy feeling, or whether they end a visit and they get that feeling of, hey, you know what, I need to step away. And I'm going to give an example of that in just a few minutes, where that actually happened with one of our customers. But this is something, again, when we talk about training, not just de-escalation training, but saying, hey, here's the policy, here's the procedure, here's where we're going to tell you when it's safe, when to trust your gut and give you the permission to leave a visit because you feel unsafe. Quick stats on this: 62% of home care workers said they received training in the last year. So that's 40% close to it that did not. And then just slightly less than 50% said that they've received a policy and procedure about workplace violence prevention. So again, this needs to be part of that training and education, that people get this communicated, not just at onboarding, but ongoing, with things. All right, I'm going to go through these very quickly, kind of at the end, as we kind of tie things together in terms of, now that you've understand who's on the committee, some ways to optimize, some things to think about when you're putting policies in place. I'd go back to leadership visibility. Culture starts at the top, and if leadership doesn't show up to talk about safety, no one else will either. We've got a group, in the New England area. I don't know if they're Massachusetts or, Pennsylvania. I can't remember, but they do a safety ride along. Their leadership does a safety ride along once a month, with someone in the field, just to understand and see what they're doing. On training sessions, they have agency leadership kick off the training session, just because just showing that they're there sends a big message that safety matters. Reporting, being transparent about reporting. So, when someone files a report or when someone files some kind of near miss or risk alert, what happens next? When we talk transparency, that's not just about tracking, it's about closing that loop. Staff need to know that their report was seen, that it was valued, and that was acted on. When I was in Connecticut last month for a safety summit, there's an agency that does, what they call safetygram once a month. They poll the staff because, one, it's required now in Connecticut, once a month, to see how they're feeling, safe or unsafe or in general. And they put those scores on that monthly safetygram. And then they include a couple of verbatims of what people said of something that they saw, whether it's positive or a threat or a risk, or some kind of violence in the field. And then they tie it to either a policy that's in place or a policy that they changed because of that specific incident. And they put it in this safetygram, which is one pager that goes out each month. Another organization does, anonymous quarterly dashboards, where again, things that were communicated and then what actions were taken as a result of that. Part of that is celebrating reporting. If the only time we talk about incidents is when something goes wrong, you're too late. So it's really shifting from, that's tough, which is what I said, to you're tough or you're brave. as a staff person who reports a near miss or a risky environment, they need to be recognized, not questioned or minimized. There's a group that does safety spotlight awards. Giving a shout out in a team meeting of someone that communicated something that changed a policy or helped, something move further, or even just a personal thank you from a supervisor that says, "Hey, thanks for communicating that," because ultimately, a strong safety culture reporting is seen as a contribution, not a complaint. You have to make sure that people know that this is something that we're driving from a leadership perspective, not something that we're just enacting because people are complaining. Metrics and accountability are important. So, tracking safety performance helps you refine those policies and show the impact. I talk about near misses. I visited a group in Florida. They mentioned that they had zero incidents in the last 6 months with, using PalmSafe and or looking at the reports in our software. And I asked them about risks or near misses. And they had that kind of blank look on their face of what does that mean? And we talked about it. And they implemented, again, making sure we talk about the ways for nurses that they promoted and talked to their caregivers out in the field to report something if they saw something or there was some kind of uneasy feeling. And when we talked the next quarter, they had increased incidents by 60%. And they talked about that being a good thing because it was an early warning system for a potentially bigger issue. Um, there's this no blame, low barrier way to report, kind of incidents. Staff surveys are important. If you want to know how safe your staff feels, ask them. Doing a pulse survey uncovers hidden risks, staff concerns, or gaps in communications. It could be simple as a text or an email. Have you ever felt unsafe during a visit in the past 3 months? Do you know how to report a safety concern? Do you feel leadership takes reports seriously? Those are some easy questions you ask that you're going to get a response on. And then do a monthly review of either incidents or the responses you get to those questions because the metrics don't matter unless they drive action. What gets measured gets managed, and then what gets shared gets improved. And that's the whole purpose of that safety committee is to manage, understand, get those metrics, and improve that process. We have a customer that does a safety dashboard at their monthly ops meetings. So again, pulling in leadership to understand and seeing that safety is top of mind, not just some checkbox. Um, you know, Challenges or things that happen as part of a committee or things that kind of become pitfalls in terms of a committee. You don't have a field staff on the committee. So it's the biggest misstep you see is that, the field staff are the ones that create and give those critical insights. Ignoring reports. Again, we talk about someone taking the time to report something. There should be some follow-up action. And then the potential or thoughts of caregiver bias. And I'm going to talk about that really quickly on the next slide because that is one of the questions we get back from people is we don't want caregivers to communicate things because what they tell us is going to be biased. It's not true. Um, we say, caregiver safety, they said, is that, input biased. It's important to clarify that the goal is not to judge that this is a bad neighborhood, but to understand and support real experiences of caregivers in the field. Psychological safety is actually recognized by OSHA as a concern. And when you ignore staff feedback, that can lead to missed warning signs. And that's where safety committees help use this input constructively and equitably. The caregivers in the field are those sensors. If you ignore the narratives out of the fear of a bias, you're going to lose critical intelligence. And so the right approach is to train your team to report facts and feelings and then use that data that you get responsibly, not to label, but to prevent harm and support better care delivery. That's the whole point of that. And two quick examples of that, these are how caregiver reports can reveal early warning signs, that aren't visible just data alone. And these could be what seem like subjective feelings or gut feeling was actually a precursor to something that's preventable. So this is a group that we work with that one caregiver consistently noted feeling uneasy in a parking lot at a complex. Her concerns were brushed off as probably just discomfort. Um, One evening after during a visit, her car was broken into. She was safe, but she was shaken because she had actually said something about it. What the kicker in this was found out was two other caregivers had said the same thing to someone else in the previous 6 months. So the lesson in this is if someone had listened or if there was a protocol in place of escalating this or communicating this to someone in a committee, they might have added, something in terms of maybe earlier visits versus dark, or something else. And so bias wasn't something that caused a concern. It was something that was a lived experience that people felt. Um, the other was a nurse. He had flagged 3 homes, not because of the location, but because they had patients who were male who reportedly asked personal questions or made kind of untoward comments. So no crime, no violence on paper, but over time, the Workplace Violence Committee connected these as low-level behavioral patterns that could potentially escalate. And so they added a brief training on boundary setting as part of their agency safety protocols, how to establish boundaries with patients. Again, taking something that was learned and understood as a lived experience and having that work in terms of, an agency safety protocol. Almost done. So I'm just going to ask this in terms of next steps. Whether you're at the beginning of your journey, we've made a case of why safety committee is essential, what it does, how it's not a box to check, but really kind of an engine that drives your organization. So whether you're, new to this and you're just starting your journey with your workplace violence safety committee, or you've got one already, I ask for a couple things. Commit to one change in the next month around safety in your organization. Bring up proactive safety at your next team meeting if you don't have a safety committee. So, again, if no one's talking about safety, then it's not part of your culture. So open that door and just ask and talk about it. Do a risk audit. If you haven't done one, start with reports that you have in the EHR or other places, or if people communicating stuff. Um, or take another look at it if you've done one in the past. So review those incident reports, the near misses, patient flags, and then see if do you have any trends with geography or visit type or shift time. And OSHA has some risk assessment tools for this that you can use to at intake, ordering, scheduling to kind of help you guide where to focus on things. I will pause here quickly for questions in this deck. I've got a couple scenarios, but we're running short on time. But you'll get those in terms of talking with your staff about certain scenarios in the field. I want to follow up and kind of end on one thing. Again, just talking about Palm. I wouldn't, be me if I didn't just talk a little bit about what we do, what we provide, especially because we give members a 25% discount on services. Um, as being partners with the Alliance. We are specifically built for post-acute and community-based care. Palm is not something that's for construction workers or for hospital staff or something else that we're kind of trying to build into this space. This is the only place we focus on. This is the only organizations we're part of, and the only places we go in terms of speaking to this or being at shows and conferences and visiting people in the field. And most people come to us thinking that Palm is just a safety button, a panic alert. And it's so much more than that because as we talked about as a safety committee, there's so many things that need to be done as part of understanding trends, giving ways to report incidents. So we have a full safety platform that includes our safety hub, which is the online dashboard that gives administrators, leadership, clinical supervisors a way to understand and track trends or view reports or push communication out in the field if something comes in from the mobile app. We talked about a ways like report. And so the mobile app is used for clinicians and caregivers out in the field to communicate concerns, to flag something in terms of visit, to set what we call the check on me timer. Hey, first time as a visit, this is a high risk visit my agency has kind of flagged for me. So I just do a check in. And if I don't check out, my supervisor is going to call me or Palm Dispatch is going to call me, just make sure everything is okay. You can give yourself a fake phone call. And we'll talk about how field staff uses Palm in that instance. And then we have companion devices as well. So if you want a wearable, if you want a physical device, you can do that as well. Two quick things. So Palm Safe, how to field staff use safe. You use Palm Safe. You can use it before a visit, and looking and understanding that ways we mentioned in the app as well as in the safety hub, you can search for sex offense registry, crime database based on a patient name or location, address. So you get an understanding of the neighborhood and say, does this level rise to be a high risk visit? So should we do a check on me? Or if I feel uncomfortable during a visit, I can set, that fake phone call where I get a call in that allows me to de-escalate and step away from the situation. After a visit, they can communicate something if they want to push it that goes to, the safety hub that they can then go into the clinical note in the EHR, or just get shared with other staff that are going to be in the neighborhood. And then in an emergency, there is, that dispatch, that SOS alert. Again, don't want to spend too much time on that because I'd love to talk to you if you have interest in understanding a little bit more about how Palm fits and how our partnership with the Alliance can help support that. And then just very quickly, on the back end, there's all these things from mass messaging alerts to reporting. So when we talk about the safety committee and being able to kind of run a committee report out of Palm Safe, you can do that to do those trends and analyze those trends, and then to also conduct risk assessments. That's it for me. I want to put the resources page here. You'll get this as well, and there's some links in here as well. You can also reach out to me. We've got some recordings and some trainings that are done by other third parties that are free if you want to use them in your next safety committee meeting, or if you want to use them to give out to your staff in terms of understanding and recognizing threats. There's tons of good information out there. It's just sometimes hard to find because if you Google it, you're going to get a lot of information about hospitals or facility-based stuff and not community. And that's something we want to try and make sure that we get out more of is stuff that specifically helps you, in home-based and community care.
Perfect.
We
Thanks.
did it with 15 seconds to spare.
We got time. Does anybody have any, right, we have 10 minutes. Anybody have any questions or comments? Anybody have any stories of your own safety work gone well or challenges? It's okay. Everybody has lunch.
I'll say one. This is actually one that's come over recently. I actually talked about this in New England. Was interesting. Is we can talking about part of protocol and being able to leave a visit. There was an instance where um, a nurse, he had gone into the home and it wasn't the patient, it was someone there that was kind of agitated and was in pacing, just kind of talking angrily about something, and felt uncomfortable and just said, hey, look, this isn't a, the visit wasn't of a type that had to be done right then. So he said, hey, listen, we're going to reschedule this visit. Don't feel comfortable. We'll take care of this, or we'll call reschedule, do something for tomorrow or the next day. And he left. He reported it to his office and everything was, approved, everything. But they come to find out when they went to the visit that I don't know if it was a brother or a family member or what it was, had continued to get agitated, went to the yard, had a confrontation with a neighbor and gotten arrested.
Oh,
And so again, when we talk about the near miss thing, if he had stayed in the home and continued to visit and that your family member, friend, whatever it was, continued to be agitated, it could have been him and it could have been escalated to, incident, with that caregiver. And so being able to have that permission of this is something I'm able to step away from, and being supported by his agency in doing that, led to that not being an incident and a liability that happened within, the nurse of the agency.
right. Well, if you're interested in getting in touch with Jonas, I encourage you to log into your new member portal on the Alliance. You do need your name and password, and it'll reset your password if you need it. But in there, there's allied partners, and click in there, and you'll find him. And in agencies, you'll find all of each other. We have forums to talk about safety or other topics as they arise in your care needs in that member-only space. So give that a look. And then also this and other programs, educations are offered all month long, and they are listed on our community calendar. We have one on the 24th on finance, on growing your smarter strategy, stronger margins. And, it sounds like a real exciting way to spend a beautiful day in July. Um, Anyway, thank you all for attending, and I will send out the recording and the slides after it buffers and posts.
Thanks,
Thanks.
Leslie. I appreciate you guys putting this together, and thanks everybody for attending and attention. And I could talk about this all day long because it's, like I said, close to me and something that I missed when I was doing this. And so, happy to hear and from any of you guys, even if you're not interested, but just want to tell me some stories and understand a little bit better about what you're doing with your programs that can help support other people. This is such a small collegial community that we have here in home care, and supporting each other is one of the best ways, sharing information for people to get better. So appreciate you guys attending and hopefully it sparked some conversation in your agency. But thank you very much.
Thank you.